Good morning. It is so lovely to see you all in person. We have really missed you, even though we have spent the last 2 years with you all on a screen. 3 years ago at the WHA, the first one that we missed, Japaigo was so excited. We were going to be releasing the World's Nursing Report. And our CEO, Leslie Mancuso, who is unable to be with us today because of a family emergency, could not have been more thrilled, I think, to release many reports than she was to release that report. And of course, it was all quite overpassed by COVID. So I am here with you today. My name is Melody McCoy. I am the Vice President of Global Engagement and Communications, and I am expressing regrets on behalf of our CEO. As you know, this is, I believe, the third day of the WHA, and thank you all very much for coming to this important conversation about reaching the unreached, all ages and new places. We are very excited to partner this workshop with the Rockefeller Foundation, and Mr. John Spangler, who is with us, will be providing some concluding remarks at the end of our event. The global health community has lived through an unprecedented 2 years since COVID-19 pandemic began, a time that challenged us all to adopt new thinking, including relating to future vaccine programs. In their efforts to reach priority populations, the rollout of COVID-19 vaccinations has countries delivering immunization services to more age groups and in more places than ever before. Some of the lessons learned offer pointers to future life course vaccination platforms beyond infancy, including school age, adolescents, and young adults, as well as the old. I'm very excited to hear from our phenomenal group of speakers and panelists today on these topics. We'll be hearing about challenges overcome in the COVID-19 vaccine rollout, as well as lessons for equity, where new ways to reach underserved populations have emerged under the pressures of the pandemic responses. But first, let me begin by introducing our keynote speakers, whose bios are in your programs today. We'll hear first from a video by Mrs. Anuradha Gupta, the Deputy CEO of Gavi. And I would also like to acknowledge Marta Tufet, who is here with us as well, the Head of Policy for Gavi. So can we please roll Ms. Anuradha's video?
Distinguished delegates, ladies and gentlemen, thank you for inviting me to speak here today to share my reflections on the lessons drawn from the pandemic for life course vaccination. COVID-19 vaccination has been the fastest rollout in human history. Who could believe prior to the pandemic that more than 10 billion shots in arms would be administered within a year to new age groups in new places? This achievement is something to be truly proud of. However, there has been a devastating impact on the poor and their ability to access services. Equity gaps have widened between and within countries. I would therefore want to emphasize 4 key lessons that should be central to life course vaccination approaches going forward. The importance of having equity as a guiding principle, the need for approaches to reflect and respond to highly heterogeneous country contexts and needs, the criticality of focusing on community demand and trust, and the value of multi-sectoral partnerships. Let me expand on each of these briefly. Vaccine equity is neither about a one-size-fits-all approach, nor about all countries or populations being treated in a similar manner. It is about ensuring that resources are allocated based on the greatest need so that the most vulnerable populations that often suffer from disproportionate burden of disease and deaths have priority access to life-saving vaccines. For COVID-19 vaccination, this means a focus on achieving high coverage in high-risk groups, whereas for routine immunization, this means a focus on reaching missed communities and zero-dose children, those nearly 15 million children who do not receive a single vaccine shot and account for nearly half of vaccine-preventable child deaths. They are symbols of communities that are bereft of the most basic services, and if reached successfully with existing and future vaccines, would yield the highest public health impact. Evidence has shown that two-thirds of zero-dose children who received one vaccine went on to become fully vaccinated. This pro-equity approach would thus lay a solid foundation for life course vaccination. My second point is about respecting the heterogeneity of country contexts. Health landscape, system strength, local epidemiology are highly variegated, and therefore vaccination strategies must be tailored to local disease burden, population preferences, and delivery capabilities. This will require a mindset shift at the global level, including increased support for country and community level ingenuity and innovation. Thirdly, the pandemic has shown a light on the importance of focusing on demand and, in particular, building public trust in global and national institutions. In Africa, child vaccination rates were considerably lower in areas with high levels of mistrust towards local authorities. And this was seen again with COVID-19, with the erosion of public trust impacting vaccine uptake. Lastly, multi-sectoral partnerships would be vital in not only reaching priority populations, but effectively leveraging every opportunity and contact point to co-deliver other basic services. Our experience with the HPV vaccine program has shown us that we need to collaborate with non-immunization partners, integrate with other services, involve community-based organizations, particularly women and girls-led NGOs, and adopt multimodal delivery strategies. We are also seeing encouraging experiments in countries to deliver COVID-19 vaccines along with other services that communities need and value. Bundling of services in an effective, integrated manner would thus be key to the success of life course vaccination. I thank you for your attention.
Thank you. We have some seats up here if you'd like to come join us. There's a couple seats over there and some others spread around, so please feel free to slide in before we get started. Thank you. Now I would like to introduce our in-person, very distinguished speakers who are here with us today. Dr. Jose Ruales, Equity's Deputy Minister of Governance and Health Surveillance, and Mr. Amir Ashraf Kawaji, Secretary, Ministry of National Health Services, Regulations and Coordination, Pakistan. And after these gentlemen give us their opening remarks, at the conclusion, we'll have a few moments for questions, as I'm sure you will have many. So with that, please begin.
Well, thank you very much. Thank you for the invitation. And I am very pleased that there are so many countries and people and organizations in this meeting. No? I can summarize the success that we had in Ecuador in the COVID-19 vaccination maybe in 4 points. No? That was leadership, participation, resources available, and an approach based on equity. And the first thing that we had a really national political priority that came from the president of the country. No? He was in charge of looking for the vaccines in a strategy that was called the vaccines diplomacy, directly with presidents and directly with CEOs of the pharmaceuticals companies, not from our Ministry of Foreign Affairs and our presidency. It was a government leadership, and that became the largest social movement in the country in the last times. No? The second, it was these interinstitutional agreements between several state institutions. We had a special initiative with our National Electoral Council. No? That permit us to have the database of every person over 16 with the place of residents. So we have the opportunity to make a geographical approach, and we develop a complete planning using the electoral roll to identify the citizens' area of residence, and we develop a mobile application we developed to verify the vaccination points and an online registration. So that get us all the people that needed to be vaccinated, where they were, and we can call them by one. The second one, the allocation of resources and the so-called vaccines diplomacy, international cooperation, the high-level bilateral agreements, and important donations from many countries. No? The comprehensive improvement of the cold chain, the strengthening of the national vaccine bank, and we had a vaccine program that is a part of our health system, and a culture of vaccination in all mothers and people. So it was easy to get with the COVID-19 vaccination at the beginning. We elaborate more than 41 guidelines and conformate an advisory committee for immunization with universities, with people from the government, with international cooperation, and a geographical information system that was organized by provinces. What were the strategies? More than 150 vaccination centers have been set nationwide in electoral precincts, in schools, in universities, in private companies, in industry, in public and private institutions, armed forces. That was the partnership. No? Everybody worked for the same objective, with the same goal. We had a daily more than 500 mobile brigades formed by under 10 population communities from our ministry, but from everywhere, no? Especially the armed forces and the university students. And mass vaccination campaigns, agreements with the private companies for the vaccination of their workers, employees, family members, community, and they delivered the medical supplies, the health personnel from the private sector. We only provide the vaccines. No? And that was that kind of cooperation. We had even vaccination of recently contacted population in the Amazon jungle, no? Population that were contacted 2 years ago, 3 years ago. We started with them going by plane, by helicopters, and that made an example for the rest of the unreached population, especially the ones that live in remote areas in the Amazon basin, in the rivers, or high in the mountains, especially indigenous population. Our constitutions define the right to health for all persons in the Ecuadorian territory, regardless of their migratory status, the length of stay, if they are in transit or whatever. In all the cases, we reached the people, especially, for example, Venezuelan migrants that were stuck in the country, in the borders during that side. Even in the people in prisons, the people on the move, we vaccinate over almost 2 million people from other countries, no? And the impact was that recovery of the social and economical activities, the decrease of the excess deaths, serious illness, hospitalizations, and 100 face-to-face classes in the public sector in the schools. And even we had some problems, especially in coverage of regular immunization activities in children. It went down about 20 or 30% less, and we had a high maternity death during the pandemic, over 20 points over the last numbers that we had in 2099. No? I think that those are, I don't have more time. No, I have to. I do have time, so I can go. What are what are the approaches that will be adopted in the next phase? No, what are we going to do next? No, first to keep epidemiological, hospital, and laboratory surveillance for the appearance of new variants. We think that's very important to develop our capacity. We develop a lot of community surveillance, epidemiological surveillance, and we train community watchers. Most of them were in place for infectious disease, for malaria, for dengue, or for other diseases. So they become the ones that watch the beginning of symptoms of COVID, and then the ones that help us defining where is the people to get vaccinated, no? And to surveil the coverage of vaccination. Now, even that we don't need to vaccinate anymore, they are moving to other public health programs, no? They are going to do surveillance in children malnutrition, for example, no? So we think that we can use them for chronic, not communicable diseases even. One, it's very important to secure the funding and the relationship to strengthen the immunization strategy with all the partners that we have, to strengthen the local capacities on internal care teams and the involvement of all social actors and other public health strategy, to reduce the human talent gaps, the personnel, especially nurses and doctors, improve information system. We are coordinating a single system that covers the entire public and private network, including the social security and the private sector. And that means that we need to improve now connectivity. We learned that that was very important to reach everyone everywhere. No? So we have now a gap of around 10 or 15% of connectivity, internet connectivity in our health centers, that we are working on that, on telehealth and application for monitoring health services, especially vaccination, preventive care of children and pregnant women, monitoring all the chronically ill patients. And we are working a lot in social communication, in education and communication, risk communication. No? We developed a new directorate in the ministry just to work in that, to strengthen the capabilities and the strategies and that technology so they can reach more, even using new social media. No, that we have to, it was very important during the COVID pandemic. No? So those are some of our experiences in the country, and we are now working in catching up coverage in regular vaccination in children and mothers. Thank you very much.
Thank you, Dr. Jose. Thank you so much. I'm honored and very grateful to be here on this getting together, putting together our heads and trying to make some sense out of what happened to the world over the last 2 years and where we are headed in future in case something similar or maybe of a lesser magnitude hits us. I was actually given a formal written text to cover this event, and I did not have time to look at it before I got on the plane. But once I got on the plane, I looked at the text, and I thought that in order to do justice to such a thought-provoking event, we would perhaps need to speak from the heart, and maybe from some handwritten notes that I had prepared for my guidance. So I'll be taking the liberty of looking down at times and covering all the points that I wanted to cover. When COVID hit us in the February 2020, we were totally unprepared for it. But we took a number of steps over the last 12 months before we started our vaccination that helped us in trying to get the disease under control. Our primary objective, of course, was that our healthcare facilities may not be overrun. So from that objective, we took a number of steps. The first of those steps was formation of a very high-level daily coordination and planning mechanism that included many ministers and many departments of the federal government and the provincial government sitting together under one roof. We managed to generate a data stream, all the relevant data points that we needed in order to take decisions. For example, the positivity each day, the people getting admitted in the hospitals, people needing oxygen, the testing capacity and people getting tested, etc., etc. So we had our finger on all the requisite data points that we needed. And we were able to take daily life decisions based on that stream of data that was coming in and being synthesized each day. Okay, after that we ramped up our testing capacity and did a number of things which is another story, but today because our focus is on vaccination. So from the point of view of vaccination, we started our dialogue with some of the leading companies which were preparing vaccines and which were only marketed at the end of 2020. So from June of 2020, we formed an experts committee which was in contact with all the leading manufacturers of the world. And based on our discussions with those companies, because almost all the companies universally required us to sign non-disclosure agreements with them before we could access vaccines. So we found out that our regular procurement mechanisms were not geared towards such procurement, because the regular procurement procedures told us to advertise, to compare prices and take decisions. Here it was getting any vaccine that you could get from anywhere in the world at whatever price. So we then were able to convince our cabinet that we needed to have a separate cabinet committee in order to oversee this procurement in a manner that was required. So that was how we solved that problem. But still there was this issue of availability and price. The availability was very low in the initial days. And the export bans that some of the leading manufacturing countries placed on the vaccines in the initial phase did not help us at all. So we discovered that many of the companies with whom we were in contact over the last 6 months or so suddenly turned around and told us, sorry, we cannot provide you any vaccine because of the export bans in place. And we were also, of course, banking on Gavi to provide us for 20% of our population cover during 2021. But Gavi, of course, was also in a similar very difficult position because of these export bans, and they suddenly found that the supply lines were very constrained. So during the first 6 months of our vaccination drive from February 2021 to August 2021, we were severely constrained in accessing vaccines, especially in the earlier months. But then we established contacts with one of our great friends, China, and at the highest level we established contacts with them, and they were able to provide us some vaccine which helped us in kick-starting our vaccination campaign. Now, because over the first 6 months we had very little vaccine to play around with, so we were constrained to place certain conditionalities for the public who could get vaccine in the first round. So we prioritized the very elderly. We started with 80 years plus. We prioritized the frontline healthcare workers who were providing attention to hundreds of thousands of maybe cases of COVID in the initial times. And we prioritized the population at risk, which was the population which had some debilitating disease which severely compromised their immune mechanisms. So we started our vaccine like this, vaccination campaign, and as we went along and the supply improved around the June of 2021, we were able to expand these age limits from steadily from 80 years that we started at the beginning to 12 years of age. And perhaps 8 or 9 steps we went down from 80 to 12. Similarly, we covered all healthcare workers other than the frontline healthcare workers, and then everybody. And we still do not have access to children's vaccine. So our children under 12 years of age are still unvaccinated. But of the population that we have targeted for whom we have vaccine, we've been able to vaccinate about 85% of our population fully, and another 7 or 8% of population which has had partial vaccination. So we haven't done too badly despite the constraints that we faced. And it would not have been possible without some of the decisions that we took along the line. So as our vaccine supply improved, we employed certain other strategies to ensure that our vaccine campaign was able to reach greater populations, greater number of populations. We wanted to vaccinate everyone of our population as soon as it was possible. So firstly, our top level planning and oversight mechanism that was already in place was also overseeing this vaccination drive, which helped. We also created then, as we had vaccine cover for all our target population, we created certain disincentives for the unvaccinated people. For example, we made it mandatory for anyone who had to undertake any domestic travel either through air or through public transport had to have a vaccination certificate, which was a centralized vaccination certificate from Islamabad. So that was mandatory. Then we also restricted the use of certain other facilities to general public. For example, sports stadiums, gymnasiums, marriage halls, and restaurants. So we said anyone who wants to participate in a wedding or wants to go to dine at a restaurant or eat had to have a vaccination certificate. So we put in place mechanisms which enforced these largely, so that all the restaurants, in those days, if you were going to a restaurant in Islamabad, there would be somebody who will be asking whether you're vaccinated or not. So that helped a lot. Now, after our vaccine reached about 60% of our population, we discovered that the vaccination drive had slowed down. So we had to take additional steps in order to improve it. So we decided to reach out to people instead of following the stationary model of vaccine centers where people came in and got vaccinated. So we now came out with mobile vaccination teams all over the country, which went to people's homes, went to the markets, went to the crowded places, and vaccinated anyone and everyone who was willing to get vaccinated. It was a huge exercise, and we used all the provinces, the federating units, as well as the larger public sector entities that we have in formulating these mobile vaccination teams. And of course, we had to recruit additional staff for this exercise, and we did that through walk-in interviews, and so that overnight we had these mobile vaccine teams in place, and they were going out and vaccinating people. We had also had help from our judiciary in this respect, because in those days when we closed down the marriage halls, we needed to close down certain schools from time to time where the disease burden was very high. So some of the people, some of the private sector entities went to the courts and saying that the NCOC is issuing orders which is interfering with our means of living. So the courts considered that and came up with a judgment that all orders and directions passed by the National Command and Operation Center are legal orders and binding on every citizen of Pakistan. So that was a great help because there was a kind of a legal void in those days when the pandemic hit us. Now we have overcome that void by creating our own CDC, which is now overseeing all this pandemic. Of course, then others have also mentioned this. We had to counter the typical disinformation on social media, which was traveling all around, either saying don't get vaccinated or saying COVID is a hoax or any new variant is extremely a great killer or whatever. But we were able to form a COM team in our health ministry, federal health ministry, which worked very closely with our experts group in countering any adverse propaganda or misinformation or disinformation on social media. And we were able to do it quite successfully. What are our lessons for the future when we go for when the world is faced with a similar sort of a pandemic or we are going for adult vaccination again? Well, to me, the first and foremost lesson that we have learned, as Dr. Jose and our colleague from Gavi had said, we need to improve the universal equitable access to vaccine. That's the first and foremost principle, because no one in this world is safe till everyone is safe. Of course, we will need regular top-level planning and oversight, which is very necessary in order to take this forward. Thirdly, I would stress on homegrown solutions, especially for the developing countries, because the various baseline situations and maturity level of existing institutions is not the same all over the world. So it may vary from Pakistan to Afghanistan, it can vary from Pakistan to India, it can vary from Pakistan to Bangladesh. So all of us have to come up with our own homegrown solutions on who to use more effectively and how to improve the capacity of existing institutions quickly. That's what would be very important for any such future endeavor. And lastly, but not the least, it is the political commitment from the highest level, which is essential on making these campaigns successful. Now, our experience and the world's experience is that in a pandemic, which is an emergency, which is a life-saving situation, such a political commitment is much easier to muster. But if there are other situations in future which are not as life-threatening or which are not emergencies, especially in the context of developing countries with competing demands for various sectors, would such a political commitment from the highest level be as forthcoming as for emergency? I think that's the question for all of us to ponder. Thank you so much.
So let's give another round of applause to our two speakers. I think you did a brilliant job of summarizing the challenges and then also offering, what some excellent takes away are. We have 5 or 6 minutes for questions. Are there any pressing questions from the audience? Okay, go ahead. Yes. Please.
Yeah. So my question is, we know the refugees and sexual minority communities like transgender community, they are not willing to give the data, and we know we have to get data because of the giving vaccination. So how do you reach them? What is your practices, best practices? Yeah, thank you very much.
Thank you.
In our case, we have about 500,000 people from Venezuela crossing the country, going to Peru and Chile, for example. And they had to stop at the southern border in Ecuador. They stayed there for more than 1 year. Most of them had some ID, any ID. No, the first agreement that we made with them and with some international organizations that were working with refugees and migrants is that information that are going to be in our health records, they are not going to share it with the government officers, no? So because they at the beginning were aware, or they didn't want to give us any ID to vaccinate. So that was the first problem. What we did is we figure a code, no, for the new identity, an identity just for vaccination, that is maintain the confidentiality of about their names or their national ID number, so they can access with the whole family to vaccines and even to health services using this code. No, that was the way, and with a number of NGOs and these international organizations, we got all the people to different places where they were vaccinated and received during the whole year the healthcare that they need.
So the development of a special
We
code.
develop a
right.
special code with to maintain the confidentiality of this data.
Okay, thank you. Yes, please.
Yeah, David Bryden with IntraHealth. I'm wondering if you might be able to comment on how you managed to make sure that the vaccinators themselves were vaccinated. I know that in many regions there's not sufficient reporting about how many of the health workers are themselves vaccinated, but the data that we have indicates that it's still insufficient. Some regions of the world where the health workers themselves are not fully vaccinated. And how did you manage to budget for the surge personnel that you would need to carry out a large vaccination campaign without taking them away from already existing essential health services or from routine vaccination?
Okay.
How did you manage that surge that was required? And were those workers who actually did the vaccinating, were they themselves paid?
Vaccinated, oh, unpaid, okay.
So perhaps I can quickly respond to that. I'd also during my talk pointed out that we had given the highest priority of vaccination even during the first few days when we had just started our vaccination drive, and we had very little vaccine to cover the entire population. So the topmost segments of our society that we prioritized were the frontline healthcare workers, and the vaccinators are frontline healthcare workers. So we started with them and then expanded. I think within a period of 6 weeks, we had expanded to cover every healthcare workers as a priority target group.
Maybe in our case, the same thing. No, the first population that were vaccinated were health workers, and when I mean health workers, it was not only first line health workers, were everybody, you know, from the administrative and cleaning and everyone. No, second thing that we searched that with the students and teachers from the university, for the medical schools, nursing schools. They were vaccinated before starting as vaccinators, and they did an online course that provided us the Pan American Health Organization. It was a 2-hour online course about vaccination with all the quality and the issues that they needed, and that was mandatory to be part of the vaccination brigades. No? So we started vaccinating the vaccinators first.
Well, I'm sure there are many more questions, but we want to get to our next panel, and hopefully if you have some other questions, Dr. Chris Morgan, who will be moderating the next panel, who is our Senior Technical Advisor for Immunization with JPIGO. He will be able to facilitate some other conversation. So let's give a round of applause to our speakers. Thank you so much. We appreciate it.
Richard, I'm assuming Richard's got mic'd up as well? Yep. Okay. So for this panel, it gives me great pleasure to introduce, from my left just here, Dr. Nyane Letsi, who's the Director General of Health Services in Lesotho. Dr. Priya Agrawal, who's the global lead for HPV vaccines at Merck. Is that right? Dr. Kate O'Brien, who many of us have been seeing far too often on Zoom for this last 2 years, who's the head of immunisation, vaccines and biologicals at WHO. And Dr. Richard Mahigo, and I'm going to get this wrong, but he is now the Director of COVID-19 Vaccine Delivery Coordination and Integration at Gavi. But Richard, we know each other very well from your past roles in WHO and Afro region. So it's great to have this panel. And as I introduce this, I want to acknowledge some of the things that Dr. Rawales and Mr. Kwaja said that I think really help set the scene for our panel discussion. The fact that in Ecuador, going to Amazonian tribes people or up into the high hills to show that vaccination can be given anywhere to anyone was a really key part of making it a norm. This is just what you do. And maybe making it a norm and making it easy is the bigger part of responding to misinformation or hesitancy or whatever. And in Pakistan, I know they manage probably the greatest variety of vaccines in the world, of any country, delivering 8 or 8+. And that's partly due to your scramble for procurement at the beginning, which helped you vaccinate your country. And those mass vaccination centres where people came in and could get tested for other non-communicable diseases as well as getting their vaccination, I think was a key. And the last point I'll make in reflection of that, what we've just heard, is from Ms. Gupta, from Ecuador, from Pakistan, we've heard about this need to bring in much more than the health sector, whether it's high-level political coordination, whether it's the other partners in the NGO or the private sector, to make vaccination something that many groups are involved in. And before I hold over to the panel, I just want to introduce our sessions shortly with just a couple of remarks. One is, I'm the immunisation lead for JPIGO. I've done that for a couple of years. But just as dear to my heart, for 25 years, most of my unpaid working hours have been spent with WHO, doing advisory roles, helping develop guidelines, leading different types of advisory committees. I chair the Western Pacific Regional Advisory Committee. And this commitment to WHO has come out of the belief, which I think is being discussed at the World Health Assembly now, that we absolutely must have a fully functional, fully funded, empowered global health organisation that does the work that WHO does. And I think now more than ever, surely that is absolutely clear. And it is great to see these two themes at World Health Assembly to actually support proper funding of WHO and also to support the work on the legal requirements at the international level so that with the next pandemic, there are much stronger, more stringent legal guards in place to help a short supply of vaccines be shared where the need is greatest and in a way that honours equity. There are other things happening at WHO, sustainable primary health care, non-communicable disease, all of which relate to our discussion, but I really wanted to make those points. And for this panel discussion, it's a little bit about learning the lessons from COVID, particularly for life course vaccination. And this slide, which was produced from our friends at Rockefeller, and Bruce Gellin, who should be standing here, who's the vaccination lead at Rockefeller, helped put this together. He was detained unavoidably by one of those, infectious events that are disrupting our travel so much these days. But he sends his regrets about not being able to be here. And it makes the point that globally, if you look right through the different ages in the life course, there are many vaccines that are recommended for some populations right through the age group, but until now, none that were universally recommended for the adults and the older adults in the world. And now, suddenly everybody in those older adult groups and down to later childhood in many countries needs a vaccine called COVID-19, against COVID-19. And the other point we wanted to make to frame this discussion is that this is a selected list, it's not all of them, but there are a set of new vaccines on the horizon that do need to be given either in adolescence or young adults or older adulthood. And so one of the key lessons is that we as a group would like to learn from COVID is what do we know now about vaccinating adults that can help us for the future? And the last point before I hit the panel is when we're talking about drawing lessons from COVID, we need to carefully distinguish, I think, the lessons of the response that particularly in Ecuador and Pakistan we saw were purely for coping with the emergency. So there are some things that you have to put in place for an emergency, and there are other lessons that can be part of routine. So distinguishing those two, I think, will be part of my challenge to the panel. So we're going to have a couple of rounds of questions, but I also invite you, if you feel like you would like to respond very quickly to somebody, to say, hey, I've got something else to say in response to what they've said, just wave at me. Dr. Letzi, you can look around over your shoulder and I will notice. Because we do want to allow a bit of time for a bit of give and take. Kate, it's IA 2030, which to some degree is framed by that top graphic. This is the Immunisation Agenda 2030, has this commitment to life course vaccination. So, what do you think this really means in practice? And what's your take on what we draw from the COVID vaccination of the last couple of years?
So I think I'm also the first one to see if the mics are working. So
well done.
Hopefully these are working. So I think everybody in the room knows that Immunization Agenda 2030 is the world's strategy. Every country of every income strata can see itself in this global strategy that was co-created by countries. It was co-created by partners. It is all of our strategy. And one of the important things about Immunization Agenda 2030 is it has a specific strategic priority on life course vaccination. One would think that maybe, as many people in this room were part of that co-creation, maybe we were looking into a crystal ball at the time, because as we've lived through and continue to live through this pandemic, and it isn't over yet, as we've lived through it, it's really interesting that each of the 7 strategic priorities and the 4 guiding principles of that strategy were so important in actually being able to respond to the pandemic through vaccines and immunization, not only for COVID vaccination, but also for trying very hard to sustain the essential immunization program for all of the antigens that countries have in the program. And there are countries that have done a phenomenal job of recovering from that backsliding that has occurred, notwithstanding that from a sort of total global perspective, we are still in a place where we have very high concerns about the lack of recovery from what happened during the worst part of the pandemic. We hope it was the worst part of the pandemic that's behind us at this point. Strategic priority 4 is this integration life course strategy priority. And I think what we've really learned, Chris, from this pandemic is that never before have adults, older adults, young adults, adults of middle age, parents and non-parents, never before have adults really seen themselves in the vaccination world. We have a literacy now around vaccination. It's amazing to hear people talk about their knowledge of different products, their preference around products, the local side effects that they have. I'm not sure that we've ever had such a literate population around R-naughts, the epidemiology of transmission of infectious diseases and how infectious diseases actually move from one person to the next, and how being part of a community is actually an important issue, not just your individual vaccination status, but who you're around, and what vaccines can do. And I think people have an incredible new understanding that there is no bulletproof vaccine. There is no vaccine that is 100% protective in 100% of people 100% of the time, but there is incredible value in being among groups of people who are vaccinated. So I think that's one thing, is this literacy around science, literacy around vaccination, notwithstanding the misinformation and disinformation that has been out there. I think we've also learned that this translates into trust or non-trust in institutions, in science, in political leadership, in governments, and in the ability of the programs to actually deliver vaccines. And I think one of the issues that is of highest concern to us is in the backsliding. We've seen some of the most severe backsliding happening for vaccines that are outside the infant program, and I want to point specifically to HPV vaccine. So in these 2 years, we've had the lowest number of vaccine introductions across all of the antigens that we have in more than 15 years. Somewhere between, depending which year you're counting, 16 to 19 new vaccine introductions, which is less than half of what we would normally see in a year. And this has particularly hit HPV vaccine very hard, and there is an urgency to catch up. So across this life course, I think what we're really seeing is total innovation around strategies for how do you get to older adults. They're not in the times and places where we would normally be giving vaccines, and so programs in many countries have had to innovate. They've had to go to vaccination in homes, vaccination in places where older people live, where they go to, and especially during COVID, this really big challenge that we had 2 messages going out. One was, don't interact, don't be out in the community, protect yourself. Oh, and at the same time, go out into the community and go get vaccination. So this, for many programs, was a really difficult sort of dual message, and that innovation to do, where it was possible, drive-through vaccinations, vaccination in homes, going to places where older people actually live, and providing ways for older people to safely get to vaccination services. So I'll wrap up there. I know you've got questions for other panel members. Thanks.
Thank you, Kate. So I'll shift to Dr. Letzi, and I'm going to come back to some of what Kate said just at the end. But Dr. Letzi, like we saw in Ecuador and Pakistan, different partners who did not normally do vaccination were brought into the vaccination process. And I know from Japago's work with you in Lesotho that it was somewhere where new partners, for example, the ones who do HIV prevention, were brought in to support the COVID vaccine rollout. So I'm wondering if you can tell us, how did that work for you in your country?
Thank you very much. And first and foremost, I would like to thank Japago for inviting us here, not only for inviting us, but for being a great partner in Lesotho during this difficult time. And you are right to say that we were successful because of our partners. I think with the population of 2 million in Lesotho, we have fully vaccinated more than 1 million. And this is tremendous work that we did. What we did in Lesotho, I think more than ever time, there was very high political commitment. We are a kingdom. His Majesty the King launched vaccination. So he was the first citizen to be vaccinated, the Prime Minister and ministers. And the task force is led by the Prime Minister. And then we have the technical working groups, which I chair, and then Japaigo is one of my great partners. What we did to make our vaccination successful, we realized that we cannot do a parallel structure. We have already an EPI program which fully manages vaccines, and we thought it should be home for COVID-19 vaccination. And then we developed one vaccination development plan. There was one national plan for vaccination for COVID, which whatever activities we were to do, it was us and partners, particularly Japaigo. We had so much human resources from our partners, Japaigo, and we employed different strategies. We realized, as the speakers have said, that this was vaccination aimed at reaching people who are not sick, people who are doing their own work elsewhere. And what we did, of course, we had fixed sites. Each and every facility was vaccinating, but quickly we realized that we were not meeting our targets. So we revised our strategies, and what we did, as I said, we are the kingdom. The honorable ministers addressed principal chiefs, because each and every village has a chief. Church leaders were called, and we decided to make a campaign. And we called our partners, particularly Japaigo, for an additional support. So there were nurses, there were data clerks, there were social mobilizers that were called in for this campaign. So what we did every Sunday, our teams were going to churches to vaccinate. We were moving from village to village. And how we did this, we had these advanced officers who were led by Japaigo and us. They would go to village by village, explain to the leadership at the village level what is this vaccine about, what is the importance of vaccines, what are the advantages before we vaccinated. So they would do the work. And they were sleeping in these villages to make sure that by the time the teams come to vaccinate, every community member understands fully what is the role of this vaccination. So this is our biggest strength. We moved out from the facilities, went village by village, and made sure that when we reached the village health workers had already registered with the chiefs or the community members in that village. So from village X, we moved to the next village, just like that, in each and every district. And then there were churches. We went to the factories, because we have a lot of factories in Lesotho. We also went to the factories. We went to high populated sites like the bus stops and other places where we could find many people. Yes, it's true, there was vaccine hesitancy, but this was managed by, we had peers in every group. Like taxi associations, we will train the peers, the influencers, to talk to their communities to make sure that they understand the importance of these vaccines. So as a result of that, we were able to reintroduce our HPV vaccination 3 weeks back, and it has been very successful. Around 70%, we are still compiling data. So our biggest challenge now as a country, we have vaccinated so many people, but you know that there have been many challenges with the COVID. Our biggest challenge was data management, but we are still sorting that. But already we are at around 70% of fully vaccinated citizens. So I think this is what I can share for now. I'll wait for questions. But I think I should mention on behalf of all healthcare professionals in Lesotho, we truly thank Japaigo during this difficult time. They were just part of us. We were planning together every day with other partners, but for them, it was more than we expected, because even during the festive season, their staff could not go on leave, because I forgot to say one of our strategies, we became very strong at points of entry. As we know, Lesotho is completely surrounded by South Africa, and most of our citizens work in South Africa. So during festive season, we're expecting more than 150,000 people to come back home. And we had to camp at points of entry to vaccinate, to screen, to test, and to do all packages of services. Thank you.
Yes, thank you, Dr. Letzi. So, Richard, this is a question for you in your Gavi role, but please feel free to answer from your, Afro experience as well. We just heard this and Pakistan and Ecuador, Lesotho, these amazing adaptations in how you actually run vaccination to get to the new populations. And Gavi is seeing this across many, many countries. So in terms of these implementation strategies, which do you think are the ones that we can take forward into the future that will be there to strengthen according to Gavi priorities for these countries in the future?
Yeah, thank you very much, Chris, and thanks for the invitation. Yeah, you're right. I'm currently with Gavi, the Vaccine Alliance, but I spent the last almost 20 years working with WHO as the Chief of Immunization in the African region. But I'm here standing in for Gavi, and I would like to thank the invitation extended to the Gavi on that. Yeah, you are right. I think we've learned quite a great deal of experience, and even today at Gavi, we are thinking about how to reflect on some of these experience in actually implementing the future program. Kate was part of the Gavi PPC meeting just last week, and one of the things that we discussed at the Gavi PPC was how and what will be the implication of all of this we are living today in the Gavi work moving forward. We are now trying to think and to shape what we are calling the Gavi 5.0 strategy, because we believe that the targets, the objective that were set for during the Gavi 5.0 strategy are still very much relevant. These are around the equity, around reaching the zero-dose children, bridging the gap between population. And what we learned, particularly during this COVID, and Kate alluded to it very much, was these new frontiers that immunization actually crossed when it comes to implementation. Remember that the COVAX was actually established with the promise of bridging the equity gap globally and playing, or also at least advocating for global solidarity. And this is a value that is quite very dear to us at Gavi in terms of reaching equity. Now, in terms of translating, of course, we went through many challenges, as you know, at the beginning of COVAX in terms of delivering the promise with the vaccines. But I think we have get to a point where I think things are now pretty much very well oiled. I think last week we crossed the gap, the mark of 1.5 billion vaccine doses that have been delivered through COVAX. That has been a major, major achievement, not only on the Gavi side, but I think on the international community working together to deliver this promise of global equity. Now, in terms of, back to your point, Chris, I think there are 2 or 3 things that I would like to come on. The first one is the innovation that we saw really not only in a very small area, but which has been really implemented in many countries at scale. And some of these innovation has to do with data. We are dealing with vaccination of adults, and in immunization, typically, this is a group that were not, let's say, familiar with many immunization programs. In my past life, I used to be the director of immunization program in my country of origin. And basically, an immunization program deals with children. And that has been the core mandate of Gavi since the beginning. But we are even starting to ask ourselves what will be the space that Gavi should occupy in the future when it comes to, for instance, the life course approach. Indeed, we are very much supporting of the Immunization Agenda 2030. Actually, Gavi play a role in the co-creation of that strategy. And it's very interesting, the discussion that are currently going on, moving not only to HPV vaccine, but also starting to think about the newer vaccine that may come, TB, and many others. We are thinking about what will be the vaccine investment strategy of the future, what type of additional strategy that we can implement to make sure that when we are talking about life course approach, it becomes really a reality for the people in the country when they are rolling out their activities. So I talked about those innovations in terms of data, in terms of micro-planning. We saw digitalization of the micro-plans, but also the fact that population, which are very hard to reach, were actually very much targeted for this campaign. And this brings really a very good question, how in a day-to-day and back to the routine immunization, we can leverage those techniques on those strategy to make sure that in fulfilling, for instance, the promise of reducing the number of zero dose, in fulfilling the promise of equity, in reaching a marginalized community. And I think in the first panel discussion, they talked about reaching people who are difficult to reach. I think we have a great deal of lesson that we can apply in the future. And this is what we are currently looking at Gavi. But it's very interesting because even the discussion, actually, I have a call with Kate this afternoon to discuss the integration and how we are going to take forward some of these lessons in the future investment, not only for Gavi, but also for immunization community as a whole. So maybe just to conclude on this, I believe we are going definitely to see a completely different world of immunization, not the one that deals only with children, probably the one that looked at the expectation now that have been set with the COVID-19 vaccination, the right for adult population to get also their fair, part of vaccination, to be included in the planning process at country level. It will have a lot of implication in terms of funding, in terms of resources, in terms of training for this new category of people that we need to reach. But I think I'm very much excited because it's a very new era that we are entering, and all of us as partners, I think if we come together, we can help countries really to probably implement this new, at Gavi we like to use numbers, maybe the immunization 2.0 era that we are going to enter in. So, yeah, let me stop here, Chris.
I think Immunisation Agenda 2030, like you said, and Gavi 5.0 both predicted the principles and strategies that we're going to need. I'm interested you mentioned tuberculosis because the new tuberculosis vaccines are fairly well down the pipeline, but if you think about it, they're going to have to be given to older adolescents, young adults, that sort of age group. And the people in that age group who need the tuberculosis vaccine are living up in the hills or in the forests, such as described in Ecuador, that they've managed to reach with COVID, or in urban poor, such as in Pakistan, where extra efforts have been made. So I think those extra efforts in COVID can maybe help predict how we're going to reach vulnerable people with TB when you have to reach them in adulthood. And Kate, I'm really glad you mentioned the human papillomavirus vaccine against cervical cancer, HPV. That's very close to Jhpigo's heart. We've worked with Gavi on HPV in a number of countries. And it gives me the segue to Priya, which is really, as you've been watching the COVID-19 vaccine rollout, have you been thinking about how that applies to HPV vaccine for adolescents? And what have you drawn from that?
Thank you, Chris. And it's really humbling to be on the panel and listen to the country experiences in terms of the success they've had. So I think the COVID vaccine rollout has been the largest global experiment in life course vaccination in history. And as a company that's been in vaccines for 130 years across actually the whole life course, not only were we watching the COVID vaccine rollout, but almost more importantly, we were watching and monitoring the impact of COVID on routine immunization programs. And there's a few things we've learned, and I want to be careful to not be an echo chamber of what others have said much more eloquently. But it was clear, I'm going to zoom out from just the resource-constrained settings, right? So we're watching programs in over 150 countries across the life course. And we quickly learned that not all immunization programs are equal. And when I say that, I mean equally resilient. Many of these immunization programs existed pre-COVID, but some crumbled and some, actually stood still and are managing to catch up. So political will, Mr. Amir, right? Absolutely clear. That's the lesson that we can learn. Countries that have made political commitments to elimination of cervical cancer then have the right policies, et cetera, that often follow. I think from a programmatic perspective, again, across the 150 plus countries, we're finding for adolescent vaccines, school-based programs, not in pandemic area, but school-based programs for life course vaccinations are just more resilient. Yes, they went down, they were impacted by COVID, but the countries that are coming back, the schools are they're catching up much quicker to pre-COVID levels than healthcare worker-driven programs. Adult vaccines, again, I know it's not a routine, but for us it is routine in many of the countries we were monitoring and watching. And there you have to have multiple vaccinator options. Any country that had an adult vaccination program that only was dependent on healthcare workers was really not very resilient. So do you have pharmacy options? Do you have vaccination religious places where people routinely go, shopping malls than hospitals, because no one wanted to go to hospital in the time of COVID, and bundling of services. It speaks to the convenience factor. When you're an adult, you want to just be like, ideally I'd love to get my hair done, my nails done, my shopping done, and get vaccinated, right? So where can you sort of bundle screening and vaccination? Also, countries that had really prioritized, not as an afterthought, but had prioritized communication, building trust. The who, what, where, when, how had significantly better uptake rates. And I was in South Africa for the first 2 years, and we were supporting the South African government, but communication was always the last 5 minutes of a 5-hour meeting, when it probably should have been higher up, with all respect. And the last one I want to pull out is that nearly every single country underestimated the hesitancy that I think the gentleman from IntraHealth was talking about amongst healthcare workers. They have been and will continue to be the most influencing factor for a person to get vaccinated. So ultimately, vaccination is a risk-benefit analysis. As you move out of the pediatric program, routine health visits drop dramatically. So you've got to overcome caution, concern, and you've got to ensure convenience. That's what we're learning from sort of adolescent and adult programs. And so you've got to meet them where they are physically and psychologically. And so one thing we've learned a lot, we could have lots of conversations about vaccine confidence and trust, but I think there was one big missed opportunity, and that was how do we train healthcare workers to use their influence, not just in the clinic and online, right? So I spent the first 2 years in various parts of Africa of COVID, and many of the decisions were being made online. Not because they were going to Google, but WhatsApp chats that then went into the villages through the daughter that had been in the urban environment, right? How do we get healthcare workers to, and I'm a physician, I was never trained to have pithy sound bites, as you can tell from my ramble here, or integrating messages into online community chats, or being comfortable with sharing our opinion outside of the clinic interaction, right? So how do we get the healthcare worker voice that is so influencing online where the decisions are being made? So yesterday I heard something very exciting. The WHO has identified 80 vaccinating influencers that have, listen to this, 40 million people reach. Now, I just want you to imagine, what happens if you give them not just the vaccine and a bike to get to wherever they need to in Ecuador, right? But actually bite-sized, influencing, trusted messaging and access to platforms that their community is reaching. So my last message on this is life course vaccination, especially as we start going into adolescent and adult. has to start with the why, whereas pediatric was the why not. Why would I not protect my child? Of course I'm going to do that. Why should I get vaccinated? You need to convince me. And I think this more consumer-centric approach is actually going to be a bit of a new muscle for all of us as we enter the life course vaccination space. So I please beg you, WHO, Gavi, and others that are now looking at the broader spectrum, that, you know, from those that have experienced this part of the spectrum a lot, it is a different ball game, and we need to perhaps focus in slightly different places.
Thank you. I really like that emphasis on communication and the why, and I hear an echo of what Mr. Khawaja was saying in Pakistan, where they created lots of reasons why, if you wanted to go to a restaurant or travel domestically and so on. Dr. Letzi, I'm going to throw to you on this communications theme as well. Can you tell us a bit more in Lesotho what you did and what you hope to do to overcome barriers to demand, to encourage uptake, to communicate why it's a good idea to get vaccinated?
Yes. I think in Lesotho what we did, as I said, we are the kingdom. We involved the chiefs. The chiefs own villages, and villagers listens to chiefs. That's one strategy. We had a big team of risk communication and community engagement officers that were going from district to district and village by village, trying to explain, trying to teach on the vaccines, COVID-19 vaccines. Now, secondly, because we have got lots of media houses, and for us, each and every district has what we call a community radio. So these community radios were involved. And then our healthcare workers in each district will visit these community radios and explain to the catchment population what we are aiming to do and why. And then secondly, as we said, we had influencers. You know, we have got peer education, adolescents, and young people. These were brought in now to target the specific groups with messages. And of course, our partners, as I said, the big team of our partners, together with us, we developed messages and pamphlets that were distributed in malls and everywhere to make sure that people are prepared and understands. Yes, we still had a bit of hesitancy in the COVID-19 vaccine, but really it was overpowered by the involvement and the approach that we used. Because in Lesotho, if you go to the chief and the villagers are gathered there, automatically when you reach there, the chief will know who is not here, who is here. And that person is answerable to the chief. And whatever the problem may be, our teams would go back to a village whereby the chief will report that my community still does not understand this issue of vaccination or COVID-19 vaccines. So we were really people-centered. I think that was our biggest strength. We did not do it the usual way. We were guided by the chiefs. Even the times when we reached the villages, we were told when to go there. Because early in the mornings in Lesotho, people go to the fields, do other work. So they will tell, okay, come in the afternoon. Unlike when we do our routine vaccinations, when we say we'll be there at 9. So it was opposite this side. It was people-driven and people-centered.
Can I add something to that?
Sure.
You know, I'll never forget, we had a informal sort of, I was in South Africa, we had an informal sort of focus group discussion going on with many of the domestic workers, some of who were from Lesotho. And when they first launched, it was still the J&J vaccine, when they first launched vaccination in South Africa, I remember the domestics coming back and saying, I wish all healthcare services could be like my experience of the COVID vaccination. And I said, what do you mean? They said, we were given a time, right? So we didn't sit there from 6 o'clock in the morning hoping that we're gonna have a turn. You know, they have a job, they need to get back. We were given a time, it was clean, it was orderly, I knew where to go, I was treated with respect. and you know, a glass of water when they were waiting to see if they had any adverse effects. And really simple things, but they just said, if only our these were women, if only our family planning services, our HIV testing services were the same. And I just thought, they're not asking for much. Like, why is it that we can do that for COVID vaccination and we can't do it for our health service, our regular health services? So thanks for pointing that out. It reminded me of something.
I mean, do you want to keep going? I think this type of innovation, this is new. I mean, comparing, say, antenatal care in many of the countries where we work, where you might wait 4 hours for an 8-minute consultation, and similarly for vaccination. Kate's going to jump in. Yep.
I think, you know, one of the things as we have this discussion is, it's actually the principles are really straightforward and really simple. This is not rocket science. Have supply, deliver services that are quality services, communicate with people about when and how and where they're available, make them available at times and places that are convenient and are accessible for people. And when you do all of those things, it works. Now, what becomes more complex is how you actually get those things done. It all starts, from my perspective, it all starts with political leadership. It all starts with the decision by those who have resources and who are going to prioritize to make the decision to make these things a priority. We have seen time and time again that the issue around accessibility is critical. And when you think of who is actually trying to access services, when they're available, where they can make themselves available, to make it so easy for people to get vaccinated, most people are willing to be vaccinated. Most people are willing to have their children be vaccinated. These two ends of the spectrum, we spend a lot of time talking about the vaccine hesitant or vaccine resistant. They're actually a very small group of people. Most people are in the middle. I call them kind of vaccine agnostic or vaccine indifferent. They'll do it if it's, as you described, an example of making it so easy to get services. And I think that's really the critical thing. And what we've learned actually through COVID is all of the different ways that it's not actually that difficult to make them highly accessible. But it does mean innovating. It does mean providing people the opportunity to go into communities that have otherwise not been served. I think the other thing is we absolutely have to diversify where health services are provided. Continuing to push people into services that are difficult to get to, not scheduled in terms of time, not a quality of service. And from the behavioral health perspective, again, we see this over and over again, the evidence that when you provide high quality or even acceptable quality services, people will come back for those services. The other issue is expanding who can provide those services. And they don't have to be, especially for immunization, it does not have to be from the usual healthcare providers. Pharmacies, we've seen many, many examples from countries about who is actually delivering vaccination services. Military being trained, pharmacists being trained. So there's a much broader remit of who can actually deliver immunization services. And then the final point that I'll make is that each of the things that you've talked about, Dr. Letzi as well, is actually collecting information about what's working and what's not working and being able to change. And so this issue of collecting data and actually finding out what is it people want, are they getting the services they want, and then adapting, being very agile. We've heard this from so many countries, is testing, trying, and then changing. And rather than being really fixed and stuck in a decision already about what works and what doesn't.
I'll come back to you in a sec, Priya, but we were talking about this earlier in the sort of 18 or so countries where Japago is supporting COVID vaccine rollout, getting this, doing the work to find out what people want, but then making sure that feeds back to those who are organising the services so that they adapt and make them work. I think getting that feedback loop really tight is important. Before I come back to Priya, Richard, you've been very patient, and I'm looking at the clock, so this might be your last chance to say something. So for Gavi, like you said, it's a child-oriented organisation. We're talking about vaccines through the life course. There is an unfinished equity agenda in childhood Do you see those two things in tension, or do you think we can work on both together?
Well, I think that's a very good question, Chris, and it is something that we are currently now, even ourselves, debating. I think back to the discussion that took place at the PPC, I think how are we going to get out of this pandemic and see immunization the same way or looking at a different aspect? I use my own term of immunization 2.0 from my past life as an EPI manager. It's very clear from what we've just the colleagues have said that we are not going to go to do the business as usual like we used to do before the pandemic. If we want really to move towards this life course approach, there are some fundamental change that needs to happen within the system itself. And I think how immunization is going to be very much anchored in a much more a well-organized primary health care system in different countries, I think will be critical to delivering vaccines in the future, particularly when it comes to adolescents, young adults, and even adult population in the future. So Gavi has been traditionally, of course, focusing on children and more recently on HPV. But I think we are asking, as I said, what will be the role of Gavi in the future in adult vaccination, for instance? I don't know. We don't know yet ourselves, because there is a lot of change that are currently going to happen in many countries. They are going to see immunization completely differently after this pandemic. Someone talked about the convenience, and if we have learned something important during this pandemic, I think is to avoid those images we had in the past where a mother will carry her baby or his baby, I think, and wait 4 hours in a clinic just to get a jab. I think this will be unacceptable. I don't know if there will be many people who will accept that again in the future. But to get services that are convenient, that are of a good quality, that are fast, I think will require a lot of reorganization at primary healthcare services, so that the mother or the father that is bringing the child at the clinic can get other contact points. Could be for checking for other condition, could be even, if it's adults, to get their jab for influenza, hopefully for TB in the future, other vaccines. And this is where, and I like your term, the why and the why not, will respond to that question. Why should I get a vaccine? Because the risk perception now for the adult population is completely different with the children for the moment. And I believe all of us, Gavi, but also the international community, and I'm sure WHO, and it's interesting, Kate, when you looked at the Immunization Agenda 2030, some of these things are already embedded in that. Now, how do we materialize that and have the right policy decision to be made to make sure that this becomes now a reality? So I think we have, as often out of this crisis, something good should come out of this. It would be to have a completely different approach to immunization, a completely different approach to primary health care, and hopefully beyond that, a system strengthening that will help to make our immunization program more resilient. We have seen how the situation has been diverse in different geography, coping with the shock of immunization. There was a conversation, Chris, if you remember, after the Ebola outbreak in West Africa, and all of us say we should design programs that will be more resilient and which will sustain more the shock of situation like that. We came out from Ebola almost the same way. COVID came, and we went to the drawing board. Are we going to afford the same thing after COVID-19? I think from what I'm sensing, there is a sort of a general wake-up call, and I say, no, we need absolutely something more robust, something more resilient in terms of system moving forward, something that will be more convenient for people to come and then to deal with this hesitancy that we are talking about. And then probably the investments that will come later on should align with those ambitions of the humanity on how to emerge from a pandemic like this with a better a system, with a better program that are responding to the people needs. So we need to design the next immunization program according to the desire of the people, and not to design a program just to deliver products. I think product is one thing, but I think the needs and the desire of the community will be quite critical. So these are the areas we are exploring at Gavi. We hope international community is also having the same discussion, and we hope to getting out of this pandemic with a much, much more different world in immunization.
Thank you.
Chris, if I may, can I just say two things?
You're going to get the last word in a sec. But
Sorry?
You're going to get the last word after Priya in a moment.
Fantastic.
I mean, I think on that issue of both resilience and primary healthcare, I finally heard somebody mention primary healthcare, which is great. I think part of it is, how do we have sustainable primary healthcare platforms that are there for the older age groups into the future, and that are providing not just vaccinations but other sorts of preventive care. And on resilience, I think part of resilience is, like our friend from IntraHealth, I'm not sure if they're mentioned, is around the surge capacity. So in half of our programs, the surge capacity came from HIV programs who were already interacting with adults, suddenly converting to add vaccination onto their existing capacity. And I think that gives a little bit of a picture of future adult preventive care platforms. But we need to wrap up, because we're going to leave 20, 25 minutes for food, refreshments, networking, so you guys can trap whoever you want to trap and talk to them one-on-one. But as we finish, I'll give Priya a word, because I think you've got an announcement, and then Kate.
So I just have two comments. One big question that I hope we will talk about as a global community, and one offer. So the question that I haven't heard a lot of conversation about is data for equity. I think, you were asking me about what was truly innovative, and that Johns Hopkins portal with that data that was live was amazing. And one of the things we struggle with all our programs everywhere is there's no real-time vaccine coverage reporting, right? There's always a lag, 1 month, 3 months, year, depending on which country. However, in COVID, we saw countries with real-time VCR data. Is that something that we could invest in and potentially have actually what we call resource-constrained settings actually leapfrog the high-income countries that are going to get embroiled in political conversations about this, right? So there's something so wonderful about if we have the data to then really be able to identify the underreached and the underserved. So that's a request. An offer I have in terms of funding, I shouldn't be saying it today because it's getting announced tomorrow, but you might not all be at the Meta event. So MSD is a founding partner and has committed an initial $20 million in funding to something called the Alliance for Advancing Health Online. You can Google it. It's a coalition with members like WHO, now called Meta, the old Facebook and WhatsApp people. And tomorrow we're launching our second round of funding. And please apply if you're interested. And this topic is improved understanding on how healthcare workers can be leveraged and supported to drive positive health outcomes via social media and online engagement, to really build confidence around COVID and routine immunization. So if you're interested, either because you're a researcher or you're interested in the topic, you want to use the YouTube, Facebook, all the different partners we have, their platforms, and you want to get funding, please show your interest, because we want the most innovative ideas. So that's the offer. Great. Over to you, Kate.
Okay. Yep. So it sort of feels like we're on WHO ground, so I think it's appropriate, Kate, you get the last word to wrap up the panel for us.
Oh, thanks, Chris. And I just want to bring sort of 3 Ps as we wrap up, to emphasize some things that were just touched on but are really core. The first is primary health care. I think everything that we just talked about on the stage here is actually about primary health care. And in Immunization Agenda 2030, it's not a mistake, it's not random that the first strategic priority is about immunization by and for primary health care. So I think we want to take that one forward, primary health care. The second is around partnerships. And again, I think everything we've talked about here and is also embedded in the strategy is the expansion of the partnerships. Adults aren't going to EPI clinics to themselves get vaccinated, but they are going to other places. And so it's about partnering outside of our usual partners on immunization, especially for life course vaccination. And the third thing is about pandemic preparedness and response. I don't think anybody here, we've all lived through these 2 years, I don't think anybody in this room could not recognize that immunization programs, vaccines, are at the heart of pandemic preparedness and response. And if you look at the 7 public health emergencies of international concern that WHO has ever declared, the pathogens are polio, COVID, yellow fever, Ebola, Zika, and I'm missing one, did I say polio? Every one of them, except for Zika, had vaccination at the core of the response. And so if you don't have a resilient immunization program, you are not ready to address a pandemic. So I'll just wrap that up by saying from the Gavi perspective, Gavi is an alliance, and the partners in the alliance are all working in life course vaccination. And Gavi already is actually investing in life course vaccination. It supports HPV vaccine. It does support campaigns for yellow fever, meningitis. It has an investment for influenza, for rabies vaccine also. And we'll see where things go on TB vaccines and others that are more sort of dominantly on adults. But it's already an alliance that is working in the life course. And we'll see where the direction heads for further investments in those areas. Thanks a lot.
Thank you. So, primary healthcare, partnership, preparedness. You heard it here. Please join me in thanking an amazing panel. And please just keep your seats for 1 minute, and I'll invite Mr. John Spangler from Rockefeller to close us out.
Wow, thank you all so much for such an exciting conversation. I was sitting there thinking, I really should have gone at the beginning of this. They're really hard to follow. So sorry if I'm not as exciting and engaging, but I just wanted to say that, for about 108 years, the Rockefeller Foundation has really been investing in innovations and partnerships that can help improve the health and well-being of humanity. And thanks to the people in this room, outside of this room, and a lot of people who've come before us, we've made really great progress over the last few decades. Unfortunately, over the past few years, we've seen a huge spotlight show us where we've fallen short. There are a lot of inequities within countries and between countries, and they're getting a lot worse. Just yesterday, Oxfam told us that about every 30 hours, there's a new billionaire minted, and within that same time period, about 1 million people are falling into extreme poverty. And so we've got a really hard course ahead of us, but we do believe progress is possible. We think that with new strategies, innovations, and partnerships, a lot of which you heard about today, we're really going to be able to kind of turn this around. And, when I think about how hard it is to reach everyone at each stage of their life course with the right vaccine, it's a lot. It's going to be tough. But I'm always a little bit inspired by how tough the global health community is. We've got advocates, we've got educators, we've got executors. We've really got the right people in the room and at the table. And so for that, we're really excited to see what we can achieve over the next couple years. And that's about it. I just wanted to thank you all for coming again, and thanks to JPICO for hosting such a wonderful panel. Thanks.
So thank you, everybody, for joining us. I believe there's refreshments available here or outside. And thank you.